So the next talk is on OG junction tumor. What is new? For that, I call upon Dr. Inian SAMARAM. He's a head of upper GI surgery at CMC Vellore.
Respected chairpersons, senior professors, colleagues, and my dear friends. At the outset, I'd like to thank Dr. Baiju, Dr. Ramesh for this kind invitation. And my brief is to talk on OG junction tumors, what is new. So this is from our unit at VELLORE. Just to show that in the recent years, there is an increasing trend in the lower esophageal and junctional tumors. Majority of them being type 2 and type 3. And IVELLO is slightly more than total gastrectomy being performed. This is over the last 5 years. So I would be briefly touching upon, firstly, the definition of the OG junction. Is there a change in what we sort of talk about true cardiac tumors? A little bit about endoscopic management protocols for early esophageal junctional tumors. The extent of lymphadenectomy has already been talked upon, so I'll just show the landmark paper and a little bit about robotic surgery as well. So firstly, we have been taught about the OG junction as being the Z line or the squamocolumnar line. Majority of the guidelines now talk about the proximal end of the gastric folds. But we're now talking about the distal end of the palisade vessels, which are these vessels here. So if you look at the distal most end, that is now being the endoscopic landmark of the OG junction. So as you can see here, all the three can coincide with each other. However, there may be instances when the squamocolumnar junction doesn't correspond with the lower end of the palisade vessels, which is here. Why this is important is one, for the definition of Barrett's, particularly the ultra short segment of Barrett's. And also, if you want to define true cardiac tumors, which is basically Sievert's type 2, you want to accurately define the OG junction. So it is important to do that. And in the recent consensus meeting at Kyoto, essentially the true cardiac tumors are now thought to be straddling 1 centimeters above and below, rather than 2 centimeters below. So essentially, if you include 2 centimeters, you're also including the gastric tumors as well. So the current thought is perhaps we should narrow it down to 1 centimeters above and below, because that is where the cardia epithelium lies. So essentially, the mucus glands without pyloric glands. And of course, we are likely to sort of see the molecular subtyping get into the TNM, perhaps in the next TNM as well. Next, moving on to the early tumors. We know what is T1A is mucosal disease, T1B is submucosal disease. And we know that EMR or ESD in particular for the early disease. So if you have T1A or T1B SM1 disease, then this is the treatment of choice. This is because the nodal burden here is less than 10%. However, the indications of endoscopic treatment is now being extended. So now there is thought of extending it to SM2 and SM3 lesions as well, so submucosal lesions. So can we do endoscopic resection in these patients safely? So these are some of the studies which are currently happening. This is the PREFER study, which is a prospective endoscopic follow-up of high-risk SM1 and submucosal disease. Can we wait and watch? And of course, if they do develop lymph nodes or if they do have lymph nodes, then can we actually just remove the lymph nodes alone do organ preserving surgery. So this is a space to watch. It is still not standard guidelines, but perhaps something that might happen in the future. OG junction lymphadenectomy has been touched upon and talked upon in the earlier lecture, so I will skip it. But of course, the change being now is this landmark article, which talks about the change in the looking at the therapeutic efficacy index, which Dr. Murali had talked about in the earlier talk. So two things have happened. One is the length of involvement of the esophagus from 4 centimeters. Now it's been revised to 3 centimeters. And the requirement for doing a supracarinal or a superior mediastinal dissection is now confined to patients who have not had neoadjuvant treatment or who have positive lymph nodes on imaging. And of course, this is purely adenocarcinomas, looking at the Tiger study, looking at the involvement of the nodes in adenocarcinomas. And lastly, about robotic and esophageal surgery. So we've got a few randomized controlled trials. The RAMI trial looked at squamous cell carcinomas. This is from China. And the advantage was, of course, the lymph node yield. And they also saw that the timing required was lesser in robotic. The RIVET study, again for esophageal squamous cell carcinomas, particularly looked at the left recurrent laryngeal nerves and the efficacy of robotic surgery for this type. And this Robot 2 trial currently underway, looking at adenocarcinomas and the lymph node yield. And this is our unpublished data from our unit, where we started robotic for esophagus about 2.5, 3 years back. And this is from our data. Again, the advantage, the short-term, looking at short-term advantages, particularly what we saw was for the lymphadenectomy alone. So just a few missing about the left recurrent laryngeal here. Essentially, you have two groups. One is the ventral and the dorsal group. It is essential to remove, majority of the lymph nodes are in the ventral to the recurrent laryngeal. So removing those are crucial. And of course, for the right recurrent laryngeal, essentially dividing the mediastinum and mediastinal pleura and identifying the nerve. Of course, if you have junctional tumors, the advantage of robotic is the intraluminal suturing and the instruments. So our preferred approach initially, when we were doing it laparoscopically, was using circular stapler. But now we do the modified Oringer technique, essentially overlapping the conduit with the esophagus and using a stapler to widen the anastomosis, a 45 stapler. So to conclude, what is new and what is in the horizon? We have the new definitions of the esophagogastric junction and the OG junction zone. And this may perhaps then define these tumors better and resolve many gray areas. We are likely to see inclusion of molecular subtyping into the classification, organ preservation both for early and advanced disease. We talked about the clarity of lymphadenectomy, and of course, AI and technological advancements both in endoscopy and robotics. I've not talked about immunotherapy, but it is changing the landscape dramatically. Thank you for your kind attention.
Thank you, Dr. Samarasan. I just got one question. Is all your esophagus presently being done in robotic, or do you choose patients, select patients?
I would say 90% of them. We do the thorax robotically. The abdominal part, we do it laparoscopically. purely because of the time, etc. But we also feel that the advantage is predominantly in the thorax. So almost all of the esophageectomies that we do, maybe about 90 to 95%, we have changed over to robotic.
Any particular techniques for left recurrent nerve dissection in robotics, making ease?
So essentially, we do the 3-port, and we might add another port as well if required. But for the left recurrent laryngeal, the first thing is rolling the esophagus. So the assistant rolls the esophagus and getting into the groove identification. And as I sort of showed there, you have to dissect the ventral group of lymph nodes, which is which is anterior to the recurrent laryngeal nerve, where majority of the lymph nodes are. And then, of course, the dorsal is the part.
All right, yeah.
Data in the presentation was that if there is a lymph node positivity, the importance of margin comes down drastically. That's the first 2 talks describes. So you usually do proximal margin for fossa section, but we don't know what is the lymph node status only during surgery. So do you recommend doing the suspicious lymph nodes also frozen? What's your thought on this? Because if that is positive, there is no point in going above and do a resection. That's
Okay, so as you rightly said, it is crucial to get a negative margin. Now, the question of whether we actually do a frozen section for lymph nodes, I think it may not be frozen sections, not accurate enough to actually guide, and it may not be practical. So I think for all practical purposes, you will have to aim for a negative margin. Be it, there with the help of a frozen section, intra-op endoscope, that is crucial. But the lymphadenectomy has to be standardized. I mean, I think you really cannot judge the extent of lymphadenectomy and the margin based on it. Another thing to actually think about is which margin. I mean, do you take the pre-neoadjuvant? Let's assume that you've got a tumor which is 3 or 4 centimeters above, and after neoadjuvant chemotherapy or neoadjuvant treatment or whatever, the margin comes down to 1 centimeter. So which margin do you take is the other question. So essentially, I think there are, the type of operation that you decide to do will have to be based on pre-neoadjuvant thing, but it is definitely beneficial. You should do another endoscope after the neoadjuvant as well to look at the margin of the involvement after neoadjuvant treatment, and then base your margin requirement based on the second endoscope.
I just want to say, is frozen section feasible at all? Because if you send a circular margin of esophagus, no pathologist can tell you that it's negative, for sure. Unless in specific cases you have some concern that there should be some involvement on the mucosal aspect or on the muscular aspect, then you can do it. That's the first question. Second is, you say that you should use the pre-neoadjuvant calculation. On the other hand, if you have complete clinical response, you could follow up the patient. These two are contradictory comments.
So basically, with regards to frozen section, I think it may not be as you're rightly saying possible or practical in all cases, but for type 3, I think when you have a difficulty in the margin, you do take only the mucosa and the mucosal rim and send it off. Obviously, with a rider that it may not be 100% this thing, but it is better than not doing it, I guess. That's and with regards to the question of which do you use to decide the treatment, I think the upfront endoscopy actually is crucial in deciding what type of operation do you do, whether you do a hyperdose or a total gastrectomy. However, you need to repeat the endoscopy, and if on the repeat endoscopy, let's say if you're reasonably sure that you will be able to get a margin with a gastrectomy, then what I was alluding to is that you be prepared, but that may be the margin that you actually are able to sort of take when you do the operation. You really don't know, you really don't this thing. But on the other hand, your operation, I think if you got a 4 centimeter tumor and you decide to do an IVLOS, don't bring it down to a total gastrectomy just because of the submucosal spread.
Thank you, Dr. Samarasan, for the excellent
Thank you, sir.